All right, so moving on to medial elbow. We can start with the common flexor tendon, which inserts at the medial epicondyle. Visualized here on the left of the screen, the tendon should be bright without any hypoechogenicity or calcification or thickening proximally. You want to slide all the way anterior till that epicondyle goes away, and even a little bit posterior to there. You're looking for this osseous swale or ditch to signify the epicondyle. On this patient, you can see the joint distally, which is a good marker because next we're going to move on to the UCL. But first we want to check out the common flexor tendon in short. So you're just going to spin with the epicondyle in the middle of the screen. You can slide just a little distal to check out that tendon. If for some reason you have a hard time finding the epicondyle, go to the middle of the forearm, have the patient wiggle their fingers. You can see all the muscle bellies of the common flexors there, and just follow them proximal, and you'll end up at the same spot. We're just passing the joint, and then there's that epicondyle. Again, looking for tendon thickening or darkness. So for the UCL, we want to find the joint. It's at a little bit more of an oblique angle. Than the common flexor, although you should still be able to see the common flexor above. But we see the joint, and then just above the joint there's a bright white line. That's the UCL, and it flares out at the proximal humerus. So it's important when we get here that we anchor our probe, and then we stress the joint by putting on a valgus load. And you could see some fluid moving in there, and that's totally fine. If it's gapping a lot, more than 2 millimeters, then we're concerned about instability. Other things we can look at here, again, the median nerve, which will be just over the ulna proximally and the distal humerus. One more tendon, the biceps tendon. We want to make sure we evaluate the biceps tendon from the medial side. There are a lot of ways to look at the bicep tendon. In my opinion, this is the easiest way, and you get the best view of it. It is a little difficult to find, but we will do our best. So it's important that the patient be fully supinated to bring the radial tuberosity closest to the surface. You can have them actively do it, or you can do overpressure to find it. I like to increase my screen to a little bit more depth just to give me more context to where I am. So in this view, you can see the radius deep, which is where we want to be. You slide just a little bit distal, the radial tuberosity pops up, so we know we're in approximately the right place. And the biceps tendon is there. Now it's just elongating it across the screen, which is honestly the most difficult part. But there it is, with the artery pumping away right on top of it. So if you struggle with this, find the artery, and the biceps tendon should be nearby. There is a bursa that lives here as well. So you want to just slide through it to make sure there is no fluid collection that might be sitting in a bursa. There we go. That's the medial side.